You've probably been told that menopause will finally give you a break from migraine. A large population study following nearly 5,000 women says that's not the full story, and for almost half of them, it just wasn't true. But there's a lot you can do about it, and most women aren't being told. Migraine is 3 times more common in women than men, and estrogen is a major reason why. When estrogen is high and stable, like during the second and third trimester of pregnancy, migraine often quiets down. When estrogen drops sharply or swings unpredictably, your migraine threshold drops and attacks become more likely. This happens through a molecule called CGRP, or calcitonin gene-related peptide. This is a pain signaling protein released from the trigeminal nerve, the nerve system that is involved in head and face pain. So stable estrogen suppresses CGRP. Falling or fluctuating estrogen lets it surge. Now, perimenopause, the 2 to 8 year transition period to menopause, depending on the source you read, is often the hardest stretch. Estrogen doesn't just decline, it swings erratically, and every dip is a potential trigger. So around 30% of women see migraine peak during this period, and attacks tend to be more severe, longer, and just more difficult to treat. And then menopause arrives, and for many women, things don't actually improve the way they expected. 2025 study, the one I referred to earlier, followed nearly 5,000 women, and it found that 46% continued to have migraine attacks after menopause, and 1 in 5 was still having attacks after the age of 60. So while women are often incorrectly told they will be cured after menopause, this just is not the case. This type of misinformation also leads to mismanagement of migraine among menopausal women. Another big misconception in clinical practice is that women with migraine can't take HRT, aka hormone replacement therapy. That's a myth, and current menopause specialist guidance is clear on this. Transdermal estrogen delivered through the skin rather than swallowed as a pill is the preferred approach for women with migraine. Oral estrogen causes peaks and troughs in hormone levels that can actually trigger attacks. Transdermal delivery bypasses the liver and provides more stable blood levels, which is what the migraine brain needs. This also applies to women with migraine with aura. Transdermal estrogen does not carry the elevated stroke risk we are often led to believe. Of course, risk must be individualized nonetheless. Between the two main transdermal options, patches are generally slightly preferable to gels for migraine specifically because they tend to produce even more consistent hormone levels throughout the day. Gels are still a solid option and are far better than oral, but if stability is the primary goal, patches have a small edge. Now, there are 3 important points that are worth noting, and I want to take the time to mention them. 1. HRT should be taken continuously without breaks. Even brief gaps can cause a drop in levels that triggers an attack. 2. Progesterone matters too. If you still have a uterus, you'll need progesterone alongside estrogen to protect the uterine lining. Micronized progesterone, that is body-identical progesterone, is the preferred form. It has a better risk profile than synthetic progestogens and may also help with sleep and mood, both common migraine comorbidities. And 3, dose titration is part of the process. Some women need adjustment before finding the level that stabilizes things. That's expected, not a reason to stop. Talk to your physician about what's right for your specific situation. Hormonal management is very individualized, and the right approach depends on your migraine type, history, overall health, and if you're struggling to get the right care, the average wait to see a neurologist in the US, for example, is 4 to 6 months. Now, this video is sponsored by NeuroHealth, a virtual neurology clinic with board-certified neurologists covering the full spectrum of neurological conditions, including migraine. You can get an appointment within days from home instead of waiting the typical 4 to 6 month range to see a specialist. Their published research showed patients had a 55% reduction in headache days within 90 days. And you can use the code on the screen for 50% off your first month, and the link will be in the description as well. So, if your migraine has gotten worse going into perimenopause, that's biology and it's manageable. If you're post-menopause and still having attacks, you're not alone and you're not out of options. Know your migraine type, track your symptoms, and have a real conversation with your provider.